So I think the for this first part of my research presentation, really that there's important surrogate measures of oxygen delivery we should follow, and the focus really is not just on improved operative survival, but reducing complications and promoting better development along the way. So the second part of my presentation, which I'm going to talk a little bit about, is really the interstage monitoring. So one of the most frustrating things for us with my team in Milwaukee was that we now had 97% survival after the Norwood operation, with deploying the monitoring and managing based on that, not pulse oximetry. And we were pretty stoked about this. We thought we were doing a good thing, but we'd send patients home and we had significant death between the first operation, going up from the first operation, and before coming back for the second operation. So 14% of the patients were dying before stage 2 operation. So now we've moved the needle. We were doing better early after surgery, but we were not succeeding once we sent patients home. And this little timeline is really looking at the the baby's ages, and kind of what we interpret their risk factors to just figure out what we were missing and how come we weren't capturing these problems during our every couple week clinic visits, and who were the highest risk patients. So we really couldn't come up with a certain theme. So, and then it wasn't just us that was seeing that. It was numerous centers, and so some of you might have heard about the single ventricle reconstruction trial, which pretty much randomized the type of shunt at the Norwood operation in over 500 subjects. And during this trial, the operative mortality, basically this is mortality of babies who didn't make it out of the hospital after the first operation, was 19%. But in this trial, 12% still had interstage mortality, which is mortality between hospital discharge and before the second stage operation. So still a real problem. And, we recognized what the potential problems were. Was it related to residual lesions or recurrent lesions? So despite a good operation, did scarring causing narrowing of the aorta become a problem? Was the shunt a problem? Were the babies at higher risk because they developed common childhood or infant illnesses? Were they arrhythmias? There were numerous risk factors we pointed to, and the only study that really looked at risk factors through a multi-center analysis at this point was the single ventricle reconstruction trial. And we were identifying some risk factors, but even shunt type was a risk factor, but only if there was a certain amount of valve insufficiency noted before surgery. So it was tough to figure out what to do. So before the SVR trial and after our early experience in the early 2000s, it was actually the year 2000, we began an interstage home monitoring program. And basically it was very crude. We said, okay, we don't really know what's going on, but we're going to send parents home with a pulse oximeter and a scale, infant scale, and we're going to ask them to weigh them every day and get their oxygen level every day. And then they're going to call us if there's breach of certain criteria that were set. We set up a multidisciplinary team. Over time, it grew into a high-risk clinic, and there was lots of communication. And we knew there was a limited number of problems that would arise if somebody's oxygen level was acutely low. So it either had to be due to the shunt or lungs or the heart. So we had a triage system that would help us sort out why a patient might breach criteria. Really, the net result is the first 24 patients, we had 100% survival, but it was 24 patients. So we then did a 10-year assessment that was published by Nancy Rudd, one of our nurse practitioners, and this was, I think, in 2014. And of the 157 patients that we sent home after the Norwood operation, the interstage survival was 98%. And I have to say that since then, it's probably stayed at least 98%. And before I left Milwaukee, I think we had no interstage death between the year 2006 and 2016. So it did make a huge difference for us. And then when we looked at the data of what happened once, so this is, the blue line is no interstage monitoring. This is survival curves. So age 0 is here, and the blue line is no interstage monitoring. The green line is interstage monitoring. And what we found that, 1 month survival was great in both groups. They were in the ICU during that time. 1 year survival, however, was significantly worse for the non-interstage monitored patients. And you can see it was before 6 months of age we had this biggest attrition. And if you could survive 1 year, then your 10-year survival is out 92%. So, earlier I said that 5-year survival was around 65% nationally. I would say that if we can get them through this early infancy period when they have the shunt in place, there are good chances that we can improve their 5 and 10-year survival. So this initiative has been picked up by the NPCQIC, which is the National Pediatric Cardiology Quality Initiative for Quality Improvement. And this is a great example of collaborative learning. Barb had mentioned Cardiac Networks United. This is a registry where they took the interstage monitoring program in Milwaukee, adapted that, had centers adopted. So now there's 65, this slide is from the fall of 2019. I think there's 68 centers that participate now. And the mortality for participating centers for the interstage period has almost cut in half. And the growth failure has also markedly reduced. So babies are growing better as well. So just a great example of taking some quality improvement research and seeing it applied across a larger scale. And I think, the big question that we all have is what outcomes are important and how do we measure moving forward? And I think we all talk about survival, but, the expectation is that most patients are going to survive. And the things we really need to focus on are some of the functional status metrics, developmental outcomes, and really quality of life. And I think research trends for hypoplastic left heart syndrome moving forward, there's probably more than this, but Fontan care, looking at different durable mechanical support options for the failing ventricle, imaging, development and quality of life, adult congenital care, genomics and precision medicine. These are all things that we've seen some version of some grants come through to stem cell therapy, and then really the healthcare quality and resource utilization. And we can achieve all this through research and through some of the collaborative learning networks because the numbers are small and it's really hard to learn just from randomized trials. And by the time that data gets produced, we're talking years where more things might have changed. So that's where the Cardiac Networks United and other organizations like that become important.